MGMA to your annual CEO Roundtable. We're very, very happy to host you all. Dean Joshi sends his best. He sent an email to Dale and I yesterday, being very excited about this program. Sorry that he couldn't be here, but having an unavoidable conflict. So on behalf of the school and Dean Joshi, welcome to you all. I'm very excited to have you all. I'm also looking very forward to the faculty conversation with those of you who can stick around after to help us inform our curriculum and some professional development for the students. With no further ado, I will introduce Clint, that you all know, and let Clint and Donna take it away from here. Again, on behalf of University of Memphis School of Public Health, welcome. Thank you all for being here. We're very excited. Clint?
All right.
Thanks, Dr. Bigler. As he mentioned, if you don't know me, my name is Clint Cummins. I'm the Chief Executive Officer of the Memphis Medical Society. We also function as the administrative arm for the local Mid-South MGMA chapter. So this is one of our best events. Excited to be here today. Just one housekeeping note before I get into the program. Some of you may have seen that the event lasts till 2. We're actually converting at 1 o'clock into a more focused discussion with the U of M faculty. You're welcome to stay and be in the audience in the back, particularly if you're a practice executive. We want to hear your thoughts and feedback, really trying to begin to build that workforce development bridge with the university. So it'll be a little bit more of a facilitated discussion, but you're free to leave at 1. We'll take like a 5-minute break, and then we'll roll right into that discussion with the faculty. So if there's confusion about our end time, hopefully that clarifies it for you. This is a bit of a full circle moment for me. So I'm a graduate of the Master's of Healthcare Administration program. I went through in 2020 through 2022. And we were the initial cohort of the executive MHA program. There were 4 of us. Intended to be online, but we knew there were plans to socialize us with the rest of the program in some way. And then something that I think we managed to leave out of the questions today called COVID happened. It created a very unique experience. I'm looking right at Mark Hendricks because he bore the brunt of some of my classmates and I's excitement about going through the program during that time. Thank you again for listening to me. I want to say some thank yous first. If you don't know this, the Medical Society owns and operates a staffing agency. It's actually a for-profit subsidiary of the Medical Society. It's called MedTemps. They're actually helping sponsor the event today, so thank them for that. Michael King is with us in the back. He's already mad at me for calling his name out, so Michael's going to wave. Michael can basically help any healthcare entity in this city meet its staffing needs. So thanks to them. Our other sponsor today is also a longtime partner, coincidentally created by the Tennessee Medical Association several years ago. Amy Herbers with SVMIC is here. We thank them for their support, and I think Amy has a quick giveaway to do.
I do. Thank you all for being here, and we have a giveaway for Janicia Richardson.
I saw Stanley on that mug, and I think that clear bag gets you in the Grizzlies game too when the season's over. So that's a very useful giveaway. Thank you, Amy. Last but not least, I want to thank Dean Yoshi, Mark, Dr. Bigler, Dale Sanders, who I think is still in the room with the School of Public Health, for really hosting us today, and also just the collaboration that we've had already so far. We've had a lot of strategic discussions, again, about what a closer relationship with the Memphis healthcare community and the School of Public Health looks like, and hopefully this conversation and meeting today is just going to continue to fuel that and keep us going in the months and years to come. I'm going to kick us off by introducing today's moderator, our 2025 MGMA president, Donna Pendergrass. I said doctor because Donna is actually a medical school graduate of the University of Tennessee. She decided to go the medical practice administration route. I think there were maybe some family motivations behind that as well. She talks about her family a lot, and that was great job in her 10 years at MetroCare, building relationships with their physician and practice members, building their educational program. She is the face and talent behind MetroCare's website, which is a lofty endeavor, and she serves as their communications director. Donna's going to moderate our panel today and ask our panelists to introduce themselves. Thanks, Donna.
Hey everybody, this is my favorite program of the year. A large part of that is because we get to learn more about our panelists. And so I'm going to ask each of them to introduce themselves and talk a little bit about where they started and how they got where they are now. So we'll start with Jenny Robbins.
Thank you. I'm excited to be here. I'm a past MGMA president. I don't even remember what year it was, but it seems like forever ago. But I'm the now CEO of Church Health Center of Memphis. We are a primary care, not-for-profit, faith-based clinic that takes care of the working, uninsured, underserved. I've been with the organization almost 18 years now, so I've been in this role for almost a year. And my journey through Church Health was starting at the Memphis Plan, which is one of our small businesses inside of the organization that helps provide managed care, access to managed care for the working, uninsured individuals, folks at QEs, dry cleaners, things like that, and then just sort of worked my way up through the organization and found myself sitting in this chair. So I'm excited to be here. So thank you for having me.
Okay, thanks. We'll go to Mitch Graves from West Cancer Center.
Good afternoon. Mitch Graves, CEO of West Cancer Center. I'm a lifelong Memphian. I've spent my entire career in healthcare, starting out with the revenue cycle at Methodist Lavonner Healthcare, and then moved operationally running the outpatient division at Methodist. And that included everything from surgery centers, diagnostic centers, home health, hospice. And I had the pleasure to go to Health Choice, which is a joint venture Methodist has with MetroCare, and form the NACO there. And one of the first in this area and market that today has grown to be very successful, financially successful and rewarding for the primary care doctors that are in there. I'm not 100% sure it was successful under my leadership, but I got it started, and they have taken it to success. And I joined West Clinic, what's today's date? May 1, 2019. And so it's been an interesting journey there, especially there had been a huge, I call it divorce between Methodist and UT and West Clinic. So I came in right on the end of the divorce, and then COVID came right behind it. So it's been an interesting 6 years of leadership through bringing a company, almost like a startup company, with $400 million in revenue day one and 750 employees. Because when we broke away from Methodist, a lot of that stuff was handled at Methodist, and we didn't know, or there was not enough stuff in place to really hit the ground running. So it's been an interesting few years. We've had a very good 2024, and we've started out extremely well for 2025, shockingly, with all the turmoil that's happening in our industry. So I'll pause there.
Thanks, Mitch. And now we'll hear from Daniel Shumate.
Yeah, thanks for being here. Daniel Shumate, CEO of Camel Clinic. Not originally a native Memphian, so I'm from Birmingham, Alabama. Did my undergraduate work at the University of Alabama, huge fan. Just want to throw that little plug in there. I did I'm an HA grad too, but from UAB. Actually see one of my UAB graduates in the back there, Brian Barbada, the CEO of MSIT. But anyway, and then kind of bounced around in Mobile and Memphis and several years in Baton Rouge, where I was a CFO there. I've been with Camel Clinic now about 14 and a half years. About 10 of those were as the CFO, and then my old boss, who many of you probably know, George Fernandez, retired, and they got lazy and gave me the job. So been doing this role now about 4.5 years. In case you've been living under a rock, we do orthopedics. But we also write the book on orthopedic surgery. It's called Campbell's Operative. First edition was written in 1930. I'm going to give you a little bit of an orientation so bear with me. But first edition was written in 1939 by Dr. Campbell, and it looked a lot different than the 4 volumes that are written now. It was more like a little notebook, and at the time, orthopedics was still a really new specialty. It was designed in such a manner that you could put it in the jacket pocket of the field surgeons for the Allied troops, and so they could treat wounded soldiers on the battlefield. It's translated in 7 different languages, disseminated throughout the world. Depending on your country of origin, it's called the Bible of Orthopedics, or as I learned from some Uzbekistan surgeons 2 years ago, the Quran of Orthopedics. So there's a lot of history at our group. We're doing a lot of things. We're up to, as of Monday, I'm looking at my family, 22 total locations in combination with our partners out in more in East Tennessee, and now we'll be up to 1,200 employees. So a lot of activity.
I would tell you something interesting to note. All of us have a finance background of some sort. I was more in the revenue finance side, CFOs. And I think that's important as we talk today and try to learn how do you get to be CEO. If you understand the core financial underpinnings of whether it's an orthopedic practice, Church Health Center, West Cancer Center, Methodist Hospital, Baptist Hospital, you got a great understanding of how the company runs. And so I think that's no doubt part of our success has been having that finance background.
Great, thank you for that. Okay, so when we hear success stories from people in our own community that we know, it can be an important confidence builder for us when we try to start something new. Can you all share with us something from the last year or so that maybe you found to be a noteworthy accomplishment by your team, or even something that you just implemented, because sometimes just getting started is an accomplishment in itself. So we'll start with Jenny again.
Well, so since I'm the newest CEO at the table, and I started officially July 1st, took over from Scott Morris, who was the founder. I think probably my biggest accomplishment is that we're still here and I'm still alive. For those of you all who know Scott, he is a visionary leader, just very charismatic, loves to get on stage, and I've always been the one behind the scenes saying, say this, don't say that. No, really, you cannot say this time. And we need A, B, and C. So flipping that role has been an interesting journey for me for sure, because I guess you would also say a reluctant CEO. We did a national search, interviewed some folks, and then just sort of the funnel closed, and it was sort of pretty apparent that I was going to be the one to take the helm. So, and I've looked at my job over this last year, threefold: protect the legacy of the organization, grow the mission, and also protect the legacy of the founder, which is incredibly important to me. And just that we have been able to do that. The community has still supported us. We haven't had to do any layoffs or major changes. We've still kept things rolling. To be a trusted resource for the folks in Memphis, for our donors, our volunteers, our staff, but our patients is really the biggest, success that I'm most proud of. And my leadership team, I was able to promote everybody from within to backfill my position. I was CFO for about 10 years, and of course, as you start to juggle your roles, you start with 3, and then you add a 4th and add a 5th, and by the time I turned around, I had, I think, 11 departments reporting up to me, and there would be no way to hire one person to do all of that, so I was able to backfill my positions with 3 fabulous key women. And so I like to say that my leadership team, we have almost 100 years of history at Church Health itself, and we're all just super sweet middle-aged women, so what I'm most proud of.
We are super sweet. Okay, Mitch?
We having financial success the last year and started out this year with what's happening in Washington, and over the course of the last 10, 11 years, Medicare's cut every physician practice fee schedule. Something in total probably over those years to a little bit more than 10%. So our payments are going down, while inflation over that same period is going up 30+%. It's not a great formula for financial success. And I think if you talk to any of us, especially in the for-profit side, like Daniel and I, our doctors feel like they just gotta work harder to make that up. And that's not a great, recipe for success. So where we are right now financially, I'm extremely proud of. We have ventured into some things that are not typically there for oncology practices. In 2024, we bought Life Signs, which is a wellness, preventive health. They do 10,000 physicals a year on people. And so we bought that to try and move some of our business, instead of it fixing them, preventing them from getting disease. And so we are just now really, 2025 is our year to sort of grow that. Anybody familiar with CAR T therapy, where they take your T cells out, re-engineer them, put them back in you, and those cells have like GPS and they're weaponized to go fight your cancer cells. And so we are one of the first 5 in the country to do that in a community cancer setting. Most of the time it's done in an academic or hospital setting because the cost of one treatment, it's a curative treatment, is $500,000. So we did our first one about a month and a half ago. The patient's doing extremely well. We're measuring all of our, making sure the patient does well, making sure we do well financially. My CFO's out there, he's like, yeah, we gotta make sure we get paid on that $500,000. But one of the first. And West has always had that sort of entrepreneurial spirit. I don't know, has anybody seen any of the stories, Wall Street Journal articles on our hologram? First in the world to have we investigated, found a hologram company, and we've got what we call hologram boxes in our Paris, Tennessee clinic and Corinth clinic, where you can get to our specialists, subspecialized breast cancer, colorectal, lung, and they sort of zoom into that location and have a patient visit. And so we literally are the first to do that. And so those are neat things that outside of the day-to-day of running the clinic that excites everybody. And so we are constantly looking, and cancer is a fast-moving, I was going to say disease, but outside of disease, the solutions. I think you saw yesterday, women's breast cancer, the cure rate is through the roof. People aren't dying from breast cancer anymore. And so that's only going to be at a faster pace of whether it's chemotherapy or treatment therapy. So we hope to be on the leading edge of that. Again, typically you don't find that in community oncology practices, you find that in academic practices. So we're proud to be on the leading edge of a lot of different things.
Yeah, thanks. I would echo Mitch's comment from a second ago about, healthcare is a weird business, right? It's a very unusual model where you provide services and you hope to get paid, right? Really, like no one would go into that business typically. And usually when people ask me, like, should we go into healthcare? I'm like, absolutely not. I would pick something else that was a little bit more certain. And, when you think about it, Mitch kind of said it, that it's a business where you're price fixed, but you're not cost fixed, right? And in physician practices, the docs live off the margins, right? And so when you've got, a downward push nationally on reimbursement, you've got an upward push on, really the cost of goods, right? That's a big talk now with the tariffs, but before that, and really since COVID, at least what we've experienced, is just really kind of a wage battle, particularly amongst licensed personnel, so nurses, rad techs, things like that. It's really hard to retain them, or you just kind of have to, fight the hospitals over, a handful of people. I know we're going to talk about the recruiting issues and stuff a little bit later, but to me, one of the things I think our team has done really well is they're a nice complement of services for, number one, what we do, and number two, particularly over the past couple of years, they've been able to roll with a lot of different variables and So we've kind of shifted a little bit in a different mode of just kind of massive expansion, acquisition models. In fact, we're going through another acquisition right now and probably 2 more by the end of the year. So it's totally shifted some of the things that we do, and most of our people were not hired to do those things, and they're still rolling with it. So I think that's when you realize that you've got a good team working with you, is that people can take some of those changes that they didn't go to school for, they didn't sign up for when they walked in, and still roll with them and knock them out and still handle the regular stress of the day.
Okay, thanks everybody, that was great. Many of us knew your predecessors who were very successful in their jobs, and all of us, well, most of us don't get to create our own jobs when we come into a new position. We generally also follow someone who's been successful in that position. Is there anything that you learned during the process of transitioning into your current position that maybe you have continued to use in your current role? Jenny?
We have to stop starting with me all the time.
Sorry, we can start the other end if you like and come back. but,
I'll
you
get
know,
it.
You sat in the front row, so.
Yeah, so my predecessor was George Hernandez. He worked at Campbell Bank for 25 years, right? So I called him Mr. Germantown because he was so well connected in the city of Germantown. He was a retired police officer, all these kind of things. Probably one of the most, or the thing that I take with me the most and remember the most about him, well, there's several things, but he taught me that to build a team, you don't need a bunch of people like you, right? You want complementary team members, and it's almost like you're building, a giant marriage, right? Where, you've got a situation where my weaknesses are her strengths or his strengths. Their weaknesses are my strengths, that kind of thing. And I think George really did a great job of filling out his team that way. And that was some of his parting wisdom to me was, hey, when you get an opportunity to build your team, when people cycle out of the organization, as they will, think about that. You don't need this, you need that. You don't want a bunch of, groupthink going on in the room. You want some people that have some expertise in different areas that can give you feedback to help you move your organization forward. So he did a lot of that kind of stuff for me, and he was, quite honestly, he's a better contract guy than I am, so he taught me a lot about reading contracts. I will say that's a good plug for the faculty thing. You need a class on reading contracts. That would be super helpful. I don't know if you have it. It's been 20 years since I've been in school, but that was kind of my feedback to UAB was, hey, you guys need some contract help in here, because there are a lot of people in your organization to get past that kind of stuff that really don't have any business reading and signing it, right? That's kind of an aside. But he did a lot of that. He was more of what I consider to be, we kind of had although it's a CFO background, more of what I would consider finance and less of an accounting CFO, and I think there's 2 differences between those 2. But he was more of a detail guy, and I was more of an idea guy, and so we worked really well together in kind of pitching things and talking them out, because I'd give him an idea and he'd beat it up and figure out how to make it actually, how we could actually execute the idea. So he was helpful in a lot of different regards, and those are just some small anecdotes about what he did.
Yeah, I think it's totally different if you're becoming CEO from internally than coming from the outside in, which I did at West. So it's a little bit different situation. He's a great leader, but we had 2 different leadership styles. And so I quickly figured that out, didn't know that, didn't work with him. But everybody kept bringing me the very simple things they should be answering for themselves. And it took me about 6 months to really figure that out, like, why the hell are you coming to me with this? And my predecessor, again, wanted to know every bit of detail, what was going on. And, we're a big company. We're $500 million in revenue, almost 780 employees, 7 locations. and you got a lot of relationships you're managing, you can't do that. And so it took 3 years to get everybody, it's okay to do that. You know, people make mistakes, just go do and make your own decisions. And so that was probably the biggest eye-opener difference between us. But as Daniel said, you know, you gotta have the right people in the right seats on the bus. And the other day I had a leadership team meeting, and again, because my 6th anniversary is in the books today. I said, how many people have been hired or promoted? There are probably 40 people in the room since May 1, 2019. And it was about 80%. Now, half of those were promotions, half people brought in from the outside. But getting people in the right place was critical. And so the 2 takeaways from that is really pay attention to what if you're coming from the outside, what people are asking you, because a lot of the times you just answer it, you move on. But you got to really dig and figure out why they are asking those sort of questions. And again, making sure you got the right people in the right seats. I can get rid of a lot of people, but they weren't in the right roles necessarily. So finding that place for them within the West family was critically important.
Yeah, so since we are a not-for-profit and a primary care clinic, you know, it's almost like we're operating 2 separate businesses, and Scott is still very much around on the fundraising side. You know, my standard line is he'll see patients in the morning, he likes to go tell stories and fundraise in the afternoon. And that's, you know, that's what brings more joy in his life, love in his life, being driven closer to God, which is what we all need to be doing. So why in the world should he stop that at 71 years old? So he's still around. But I think, obviously, the biggest difference between Scott and myself, he's a doctor and a minister, and I am neither. So it's been an interesting journey. You know, of course, on July 1st, I thought I was going to do all of these things, and then I just had to sit for a minute and just watch what would happen. You know, because I had been in the role for 17 years, or at the organization for 17 years prior, so I thought I knew everything, and it took about, you know, maybe day 2. I think we had a, you know, 2 or 3 things right in the first 3 days of our, you know, start of our fiscal year that happened that just caused me to fold, you know, close the chapter, wait just a minute and stop and listen and look. And so I think we've stopped some of our strategic planning process that we really wanted to get started in the first quarter, and now that's really started now, and just a couple of other things. But listening to the folks, asking questions that I think I know the answer already from the CFO role, but to ask it just a little bit differently is definitely new, a change from my CFO role to my CEO role. And then trying to look at it through a lens of what would Scott have done, or ask, you know, my directors and other leadership team, what am I missing? Usually those leading questions are the ones where I actually get the answer. I appreciate the skip level meetings. I think I've got some church health folks in the room who know that I'm all about the skip level meeting, because that's where you get your truth. You know, because it snows upwards, I like to say. But just kind of asking questions a little bit differently has been probably one of the things I didn't think I would have to do as much of, because I thought I knew all of the answers, but, you know, I didn't have them all. And then making sure, you know, that everybody's got their great ideas, and everybody wants to do this tomorrow. And yes, we are a not-for-profit, and we have to fundraise, and we're so dependent on our doctors, you know, our primary care providers who we have on staff, but then all of the volunteers and subspecialists and other groups that make, you know, church health work. But making sure that we don't entertain every great idea, and wouldn't it be cool if, avoiding mission creep is probably one of the biggest lassos that I have to make sure I'm reining in almost every day, because everybody's got a great new partner that they want to talk to, or a great new idea that we should do. That, you know, we are a faith-based not-for-profit, we are a primary care clinic, so we want to make sure that we are doing everything we can inside of our primary care role, so that, you know, prevention is the key. Mitch already talked about that, but when we are really looking at how we can activate the patients, and especially the underserved and uninsured in Memphis? How do we keep them out of the specialist office when they're woe bad sick, or how do we keep people out of the emergency departments? We've got to focus on what that looks like more than what's the great new idea. So I think, maybe I'm rambling off breath question. But the differences between Scott and myself and all of our shoes, I'm building new shoes to fill. I'm not filling his.
That's great. And thank you for reminding us all how much church health does help provide a safety net for all of the rest of us in that preventive healthcare role. I think maybe some of us don't think enough about how much church health does that for our community. And so thank you for reminding us of that. Okay, now moving away from the past, let's talk about some forward-facing priorities for your organizations. Can you name for us 1 to 3, sorry, not 3 for everybody maybe, 1 to 3 opportunities that are at the top of your priority list this year, and we'll start with Mitch this time.
Yeah, I will tell you, there are a lot of organizations that talk about strategy, but it's a once-a-year deal, and you go on and put it back on the shelf, and pull it back off next year. That's not Wes, that's not us. We spend a lot of time on our strategies, our pillars that support our mission, our values that support the organization. And so strategy is a critically important element to our team. And we've got 7 pillars that we focus on: clinical excellence, growth, research, financial sustainability. James is looking at me out there, make sure I cover that one. Education, and we added one this year because it is a bigger part of the design of the company, and that is value-based healthcare. Shifting from volume to value. And so as we look at each year, we have different action plans, but those pillars we stay extremely focused on. And if somebody's bringing me the next new brilliant idea, I ask, is that on our strategy map? Is that something we really think that we need to add to that? Sometimes it is. Value-based, we had that debate this year to add that in. And in the cancer world, again, it's a fast-paced, changing world out there. And to ground the organization, everybody needs to know what we're focused on, and that they don't get confused doing other things that don't lead us back to supporting the mission and vision. So again, a lot of organizations, some you probably work for, have a strategy that's out on the website maybe, mission, vision, but we live and breathe it every day. And everybody knows it. Everybody on the senior team knows that. So I think we don't vary a lot year to year of what we focus on. We may have different actions we take every year, but our core strategies, we don't change very often.
Thanks, Mitch. Okay, Jenny, I think you were going to comment on this one?
Yes. So we are, we focus on stewardship, relationship, and excellence. And so the relationship piece about our fundraising, how are we going to fundraise $20-some-odd million every year in the face of a recession? So how do we keep on telling our stories and make sure that we have got good success stories that are going to appeal to the masses? We ask for time, talent, treasure of the community, and we've been doing this for 38 years, and so we've got to make sure that the message is still strong and clear. So that is a huge focus. Excellence, I've mentioned that we are a primary care clinic that's mostly our staff, and how this year we need to focus on making sure that our primary care providers are doing absolutely everything they can, as much as they possibly can, working at the top of their license to make sure that when we do send a referral to West or Campbell, or all of you all in the community, that we have made sure that they're a qualified patient. If they qualify for Medicare, Medicaid, a traditional health insurance plan, we're going to help guide them to that. But then we're also going to give them the health tools to make sure that they've got the diagnostic tests that they need, that they've got all of the check boxes before we actually send them to a provider. And so we want to try to make sure that we can do that as best we possibly can. And then the stewardship, making sure that we are stewards of your funds, your time, and then making sure we've got the staff to do all of those things. It's Patient Access Week, so we're celebrating that group right now, because those are the front lines, the people who answer the phone, the front desk, and if, we've got to make sure that they have the tools and everything that they need, the soft skills to talk to the patients, to understand. I mean, because some of these folks have never had insurance, have never gone to a doctor, and don't know all of the acronyms, nor do I. And so how do we guide them through that system of care? But we've got to make sure that we're taking care of those folks. So I think the primary care focus on the stewardship side is huge for us too. So stewardship, relationship, and excellence are our three big pillars.
Great, thank you. Okay, access to healthcare continues to be a problem at the forefront of our industry, especially here in Memphis. Nearly every specialty is experiencing shortages in physicians and or workers, but for some people, access isn't simply a matter of provider availability. Talking about access naturally has led me to thinking about Church Health, which was created specifically to expand access to healthcare. Jenny, do you have, I know you kind of got into that already a little bit. Do you have any further comment about what you're doing for access?
The continuity of care at the family level is also something that we want to make sure, we can take care of the whole family. You might have a father who is uninsured and working in a low-wage job, but the mom is at home with 3 kids and they have 10 care, and then they might have a grandmother who's living with them. And it's really hard to coordinate all of those care plans if you're at different places. So if we can find a way to take care of that whole family, that's what we want to do. Because a lot of times, we work on what's called the model for healthy living. And movement, medical, nutrition, emotions, faith and family, or faith life, friends and family, and work. All of those things need to be in balance. And medical is just a portion of that. But inside of the family dynamic, part of healthcare and prevention, all of that, it's something else that's causing that wheel to not roll as easily as it should. So we want to make sure that at Church Health, we've got the tools and resources internally that we can take care of as much of that as possible before we have to go and tap resources. Because yes, some people, they will need cancer treatments, they will need ortho treatments, they will need radiology, they will need all of the things in the emergency department. But if we can work on the prevention piece to try to help keep all of those things together, that's really where we're focusing our time and resources.
Thank you. Daniel, sorry. Daniel, obviously Campbell Clinic is very different sort of practice than Church Health. Can you talk about how your organization is working to help with access to health care in our community?
Yeah, to me, there's 2 different components to this question, but I will say we have I guess it is a written saying at our practice, but it's faith, family, and then the Campbell Clinic, and that kind of shapes what we do. And so while we are a for-profit business, a lot of our decisions are not based on that. In fact, most of our growth strategy is not necessarily based on that. First of all, I think everybody knows that it's very challenging right now to recruit to Memphis, whether that be higher level employees or whether that be physicians. And traditionally, we have not had a difficult time recruiting physicians to Memphis. It's actually been pretty easy. On top of that, we have a residency program, so it's kind of like a Major League Baseball team, like a farm system. You just call up the guys you want, But what we're seeing now is that even a lot of residents are choosing to move elsewhere. And in case you saw it the other day in whatever paper it was that it came out of, maybe the Commercial Appeal, but Shelby County had more residents leave the county over the course of last year than any other county in the United States. That to me is a really scary statistic. But it's not that everybody's fleeing the Mid-South, right? It's just a lot of Shelby County and the current crime conditions. So what we want to do, and the kind of strategy that we developed a few years ago, is we're going to go to the communities where the people are, right, and where they're moving. Because even though we don't sell commodities, to a lot of people, a sprained ankle is a commodity, right? It's just, hey, I need to get this treated immediately and find out whether or not it's broken, I'll go to the nearest stocking box that I can find, and there's stats and stuff on how far people will drive to get to certain specific services. They're going to drive into Durham for or Memphis for surgery, but they may not do that for an MRI. They may not do that specifically for like PT and office visits. So one of the things that we've done from an access standpoint for our patients is make sure that we get into the communities. Like we're just opening an office on Monday in Millington, that we get out in the communities where we feel like they're underserved from an orthopedic standpoint, and where people don't have the quick access to some of the basic care that they can get, knowing that we can funnel the harder issues, the MRIs and the surgical procedures back into kind of the mothership. So almost think of it as like a hub and spoke model. In addition to that, we've traditionally taken, we operate at Honor, we're the ortho guys exclusively at Honor and Regional 1. And so we take a lot of patients, right, that come in the door, and not all of them do we get paid for. And that's been going on for, the existence, right? But we are expanding kind of our insurance offering and going into Mississippi Medicaid. Part of our strategy is to expand into Mississippi. And, I'm trying to remember the stat. What is it? It's like 1 in 3, I think, in Mississippi, or 1 in 4 in Mississippi, or on Mississippi Medicaid. And under the age of 20, I believe it's 1 in 2. So it's a very poor state. The reimbursement is much different than it is in Tennessee. But if we're going to, do business in that market, we need to offer all the services available to those patients. So.
Yeah, we're down in Mississippi, Arkansas, rural West Tennessee with locations. And we at West, we call it, we don't do wallet biopsies. So it doesn't matter, you got money, got a lot of money, we're going to take care of you. It is harder to recruit here, but I will tell you in the past year, we've recruited a new ENT surgeon, a new pathologist, 2 breast surgeons, 1 gynecologic oncologist, and there's somebody I'm leaving out. But so we've had a pretty good 12 months. We are also re-engaging, you heard me say earlier, we got a divorce between UT, Methodist, West. The university has a phenomenal new chancellor, and so we are re-engaging with them to get back in the fellowship programs and convince those people, doctors, to stay here, do their fellowship here, stay in Memphis. But it goes further beyond just the doctors. It's the ultrasound techs, the nurses. We are actively engaged with the University of Memphis School of Nursing, UT School of Nursing. These are great paying jobs. Ultrasound tech today can make $75,000, $80,000 bucks. Mammo tech, $65,000 to $80,000. And but there aren't enough kids in school, not enough teachers either. So we have started a dialogue with the Chamber of Commerce about how they should be engaged in this. We spend a lot of time trying to recruit companies to Memphis. We don't spend enough time in workforce development. I believe we could identify kids in high school, in the 9th, 10th grade, and start to train them to be ultrasound techs, mammo techs, x-ray techs. And by the time they graduate, they're at a $60,000 a year job. Not all kids are going to college. And, we miss the boat here. We've got a lot of demand. I don't know how many openings you've got, but I've probably got about 45 today. And these are well-paying jobs. Don't have to have a college degree. And as a community, we need to, and again, that's why I'm on the chamber. I think that's one of their deals. They should be working with the school system. And we ought to have kids coming out of high school prepped for jobs in the medical field. And we don't have that today. So there are things we do wrong as a community. There are great things we do. The University of Memphis has great programs. The University of Tennessee has great programs. But not everybody fits that slice. And we got to do better at that as a community.
Thank you so much. Okay, the meaning of the word advocacy can vary dramatically depending on the situation, but for MGMA, advocacy really is about legislation on behalf of our practices and their patients. It's the core of our organization, really. So I'd like to ask you all if there's any specific legislation or topic that you've been following closely at the local or state or federal level. Jenny, would you like to start?
Well, so Clint and I are both on the board of the Tennessee Charitable Care Network. So obviously the uninsured and underserved is always top of my list of what the legislature, General Assembly is looking at. The safety net funding for those folks is critical. That's always a line item in the governor's budget. Of course, we look at the undocumented, anything that's going on with the undocumented workers, what do we need to pay attention to for there, to make sure that, that we can still treat them and keep our 501c3 status, because we don't want to turn anybody away because of their documentation status. And then National Health Service Corps funding, any workforce development funding that's in the Assembly budget, we want to look at that. Any loan reimbursement for text to providers is something that, as a not-for-profit, that is a huge recruiting tool. And Mitch mentioned that chamber piece. Bill Donovan does a fabulous talk about everything that's right with Memphis. And if you haven't heard him speak yet, or you have another group, or this group wants to hear him, he loves to do that talk. And it just, focuses on what Memphis does well. And I do think any recruiting piece that the legislature has that they could be helpful with the medical field is really important. But we're not for profit, so the payers have other things.
Yeah. We are definitely watching, not much at the local level per se, state level definitely, federal level very definitely, and we all are watching to see what happens. Do we get any relief from the Medicare cuts to the physician fee schedules? Do we just telehealth continue on as we're using it today, which is one of those extenders to allow you to reach a lot more patients. But that's only through September. And so we are actively monitoring that in our world. In the cancer world, there are so many different legislative agendas out there, basically about drugs, whether it's the PBMs, the pharmacy benefit managers, or the manufacturers, or why do we pay 3 times what somebody pays in France for drugs? And so drugs, you will see that is a heavy topic today in the Trump administration. For those of you in the hospital world, it's a scary outlook. There are all sorts of bills out there to cut your disproportionate share. There's a hospital tax that gets matched 3 to 1. Very successful down in Mississippi last year, and those hospitals are getting paid at commercial insurance rates for Medicaid business. It's a great deal. It doesn't cost the state anything, the feds pick it up. That same legislation, Tennessee pushed to Medicare. It is on hold. The Trump administration's put it on hold. If you're reading Wall Street Journal reader, you've probably seen 2 articles in the last 2 weeks about trying to do away with that whole hospital tax mentality and the federal government matching it. It's costing the feds $2 trillion a year to fund that program. Now, as providers of Medicaid and TennCare services that have not had an increase since 1998, I'm a little pissed that hospitals keep getting money for the Medicaid program and we're taking care of them just like everybody else. So there's a lot of brokenness in the system out there that somehow needs to be overhauled. And I don't know if anybody's got the wherewithal to do it. But hospitals, if you're at a not-for-profit institution, you got a lot of stuff, especially if you're a 340B provider, try and do away with that. Or at least try to pay it at a different rate than they're paying today. If you're a hospital, I'd be worried that this is going to have huge impacts. We've already taken our bet this year, but I would tell you it's coming. And again, the drug portion from our world is critically important. It takes our margin on drugs to keep the practice running because Medicare's cut everything else that we get paid. So it's a crazy system, as Daniel mentioned earlier, but it's a system that we live in, and it makes us have to manage every year to whatever is happening in the reimbursement world.
Yeah, I think to that, you know, we always talk about the Medicare fee schedule and watching it go down, and I think the stat through 2023, 2024, since 2001, when you adjust it for inflation, the physician fee schedule is down like 23%, something like that, which is, you know, hard to do business under that model. But we always focus on Medicare, but, you know, if you go in the contract world, you know, contracts are built on Medicare. And so if you have contracts that are built on current year Medicare rates, and every time Medicare goes down, so does other contracts. So it can have this kind of rippling effect. But I think sometimes, you know, particularly being in this size of business, you feel kind of helpless on that side, right? Because national policy is really hard to change. Even though I feel like we've got a good representative in Kustoff who actually cares about physicians, still feels like it's really hard to drive the needle there, right? The hospital industry has a really good lobbying power that physicians, quite frankly, just don't have. Sometimes it makes, I feel like makes some of those national policies very difficult to change. But, you know, kind of state level, we've been most interested in the bill that actually just passed. I call it the AA bill, but the anesthesia assistance bill. And since we do obviously a lot of surgery, it's very important to see like what this does to the anesthesia industry across the state. And for those of you not familiar with it or maybe familiar with it, there is a, you know, it's very prevalent in the Memphis market, but it's also prevalent statewide. There's a crazy thing happening in anesthesia. There's been a shortage of the providers. There's been heavy penetration in private equity, which has basically turned into this huge wage war for CRNAs. And so now you have CRNAs making exorbitant amounts of money out there, which has been challenging for the anesthesia providers to match that. You know, it's kind of one of the private equity strategies, right? As you come in and you destroy the wages in the community to force the little guys out because they can no longer pay the CRNAs the rates to keep them. And then now you're forced to contract with the PE group because nobody else in town exists. So basically what this bill does, and it does a lot of things. There's some corporate practice in medicine that actually affects Brian back there, or potentially could, where hospitals now can, own radiology and anesthesia, but essentially lets the assistants operate under supervision of the anesthesiologists, which could potentially have a downstream effect on CRNA rates. And so how that affects like my business and why do I care, we need more of these people in here to be able to operate. So there's some of the hospitals around town have been at critical levels in being able to do case volume. In fact, there were some hospitals with Memphis that were at 50% volume for an extended period of time because they couldn't get anesthesia providers to work. And so, you know, that's obviously a core piece of our business. So we're hopeful that it'll flood, you know, the market and it'll kind of calm some of those rates. There's a lot of subsidy talk in the community. In fact, most places pay subsidies now, including for years, the ASCs didn't pay any sort of subsidy rates to anesthesia providers. And now that's kind of become a norm. So it's been a real disruptor to the community, the access, you know, it's probably something we could throw into the access of care, right? If you can't get surgery done, you know, you can't have your healthcare reform, right? So it's a little more like Canada. So anyway, that's one thing that we've been really excited to see. We've been pushing for it. In fact, Dr. Todd Rowland, who's one of our physicians, is the president of the Tennessee Orthopedic Society, and he's been back and forth to Nashville lobbying for this bill, and it passed. So we'll see if his efforts were actually positive or whether they didn't do anything. I guess we'll find out. So.
At the state level, and I think that's only in counties under 105,000 for the corporate practice, is that right, or is it everybody?
I think so. I've been less concerned about that because it doesn't affect us, but there is a weird piece to it on the, Ryan may speak to that, but there's a weird piece to it
I didn't know that.
on the anesthesia side of where the assistants can't do it in counties less than 85,000. And when you start to peel back some of these bills and wonder like why do they have these weird kind of requirements like that, usually it has to do with somebody who's sponsoring the bill or somebody who was key to get the vote to get it passed that lives in that particular county that has somebody in there that's pulling the strings telling them that we need this. And I think that's how that one kind of played out. Because it's a very unusual, it happens to fit certain counties where 85,000 or less where it won't affect them.
We had a good year in Nashville, thanks to the TMA and others, American Cancer Society. Stage and insurance companies try to always make a cancer patient go to the lowest cost drug first, even though we know that's not going to work. It may not be best for the patient. And so it's called step therapy. They make you have that one first before you get to the real drug that's going to help you. And so they were successful this year, at least. If you got stage 4, you don't have to go through step therapy anymore. You can go direct to the drug that your doctor wants you to have. So that was successful. The other bill we were behind is allowing for payment of biomarker testing, which we believe is critical to the future of cancer care. And it'd be nice for the state to force insurance companies to pay for that.
Yeah, has anybody ever seen the movie Rainmaker?
Yes.
Yes.
You gotta go watch that. It's a Matt Damon, Danny DeVito movie. It was actually filmed here in Memphis. And so it was back when I think Matt Damon was a kid, essentially basically filming this, and he's an attorney. And they take on the case of, it was actually a cancer patient, his bone marrow transplant is what the kid needed, and they denied the case, and right, you fast forwarded it, well, I'm not gonna ruin it for you, but, although it tells the story that I'm trying to tell here, but, today, what they were doing then in that movie is what I consider like modern day version of pre-authorization, where it's just a, legal way to deny care and to limit access, and right, we all know there's a math problem behind that because the insurance carriers are paying some third-party company typically to manage the process for them, and they know, hey, if we deny X number of services, these are going to be the peer-to-peers that are actually done, these are going to be the things that go to fruition, this is what we're going to pay, we're paying these guys this, we're going to net a delta of that, right? Like that's the pre-auth model. And somehow it's legal, but in Rainmaker, they found a way to make it illegal. Actually, the company trashed, but anyway, go watch it. But pre-auth was always something that I feel like we argue for every single year. And they made some changes to that over time, but it's still a really bad system.
Thank you all so much for all that great information. I know with all of that stuff, maybe we might have a quick question or two from the audience.
I'm Philip O'Malley, I'm the CEO of the Urology Group, and I have a really big concern with crime in the city and what we as leaders can do, and with MGMA, like what are we gonna do? I'm happy, Mitch, that you found people, but I myself, 500 urologists retire a year, 300 come out of training. I can offer arguably one of the best packages in the United States, and I only get doctors who grew up here, married someone from here, or grew up in a small town in Arkansas or Mississippi. I can offer a great package, work life, all the things that they want, and they all say, I don't want to come to Memphis because of that. The University of Tennessee also has this problem. I've talked to several chairs that said they had to soak for positions. So soaping in residency means nobody said yes to us. And they go and start calling schools to find someone to take that spot. That's not good. That's a direct indication. Nothing changed except the crime, I would argue. And I feel like we have to do something to lobby. Something in Memphis has to change, because the more and more doctors retire and leave, if we're not refilling them at the rate that they're leaving, when people ask me the two biggest issues for their healthcare, I tell them it's private equity and crime not getting doctors to Memphis. Like, what can we do for that?
Well, I tell you, not an interview that I'm bringing somebody in from out of town, and those 6 doctors, every one of them came from outside of Memphis, so they did their fellowship or residency somewhere else, at top schools. You know, crime is in every urban area. I would tell you, I interviewed a couple of fellows, one up in Detroit, I've forgotten where the other one was from, Oakland, California. And they said, you don't have anything on our city's crime. And so that didn't bother them, and they recognize that. But it is, and especially if they've got families. And, you know, I live in the core of the city, lifelong Memphian. I want people to live in the core of the city. And we've got a realtor we use, takes every candidate around, we interview them, take them dinner Thursday night, interview them on Friday, Saturday morning, they go with the realtor. And I've used to chastise our realtor for taking them direct to Germantown and Collierville. I'm okay with that now, because that's what it takes. Because they read about the school system. Hell, if you Google Memphis school system, you're going to say, what is going on? I never want my kids to go to school there. Suburban schools, totally different, but you don't get past that. We can put in Memphis. Crime's not going to be solved overnight. I don't believe there's a magic switch to turn on. I believe we have got to have better jobs, better education. You know, when we've only got 23% of 3rd graders in the Shelby County school system able to read at a 3rd grade level, that's a real problem, because they can't catch back up and be successful. So the interventions that have to happen, I'd love for there to be a healthcare solution to that, but I agree with you, crime's an issue, and it hurts recruiting, but it's gonna take this community coming together and figuring out those solutions. And a lot of it starts at the education level, and how can we get jobs out there, you know, instead of turning to crime, go be an ultrasound tech, make $90,000 a year. What a great living. You can own a house, you can have kids, but we don't focus there yet. And so that's where I think we have got to come together and figure that out as a community.
Yeah, I wish I had the direct answer to your question, because I probably wouldn't be sitting here, right? But it's a challenging thing, and I think we all face that in some capacity or another, right? And kind of mentioned earlier that we've traditionally not had, difficulty recruiting physicians here. We've got a good brand name that attracts, and we've run into that issue right now. Particularly since we service a lot of hospitals that are in the downtown area, right? If you just service Methodist Germantown and Baptist Collierville, probably not a big deal. I'm the same way as Mitch. I usually tell, in fact, we're interviewing a husband and wife team, which is unusual, but anyway, she's interviewing with him, and he's interviewing with us, and I'm meeting with him next, and, they're not from here, right? We're trying to keep them here, and that is certainly an issue that weighs on their mind. In terms of solutions, one, I think we have to have police departments that are funded to be able to handle the crime. I mean, crime is actually down, I think, statistically this year. What would help is that, when you get put number 1 on that list, it shows up everywhere in social media. And so now everybody sees something, and you're like, you're number 1 in crime, you're number 1 in crime. When that drops to number 8 or number 7, people don't talk about it anymore, right? Like, a few years ago, we were, somewhere in that list, right? I mean, it's always been kind of a dangerous place, but not like this. And the recruiting problems were nowhere what they are now. So they've got to figure out a way, 1, to get the department funded, and 2, make sure that it's run right to get some of the crime down, right, to make it a little bit more of an attractive city to be there. But quite honestly, I don't have a good answer for you on how that happens.
And another piece of that, and I don't know the exact percentage, but it's definitely female physicians are it's a greater percentage coming out of school today than male. And so you gotta really look at, I can't look through it, but I imagine I look through it in a female's eyes. And you gotta really see where, are they gonna be in a safe environment? Are there kids? We've got more flexible schedules than we've ever had, especially to accommodate female physicians that have multiple kids, and the husband works. And, you know, and we do have a lot of husband-wife physician teams. I've got 1, 2 surgeons, somebody's always on call in their household. And so, you know, the changing of the demographics, you gotta adapt to too. And I would highly recommend you take a new set of eyes to how you recruit and who you recruit. I don't know about that in the urology world,
Yeah.
how the male-female piece works, but I'm interviewing more female medical oncologists, surgeons than I ever have.
You know, that's a great point. We're actually changing our physician contract I went to the orthopedics least diverse subspecialty in medicine. And, you know, it's traditionally been a white male dominated subspecialty. And so there's been a big, not a big shift, but there's been a shift, right? In fact, we just had a residency match, and 4 of the 8 that matched were women for the first time ever. So it was a huge shift, but we're changing our physician contract to accommodate really the growing need of women in practices, right? And we compensate our doctors a little bit differently. That's a discussion for another day. But you know, I went to a seminar a couple years ago and listened to it was nothing but women orthopedic surgeons talking about going through pregnancy and then what happened afterwards. 2 of the 4 women on stage rounded the day of giving birth. And I was totally blown away by that. One of them was back to work 3 days later, the other one was back 2 weeks later. And it's because of the way the comp models are set up. That's not attractive for a female to stay in the workforce that long, right? Particularly if you get into a situation where they're married to another physician or someone that has a high income and can afford them to go on. So you're trying to recruit female physicians who not only will come, but will stay, right? And so we now give 6 weeks off, or we assume it'll get voted on in June, 6 weeks off paid to female physicians for, you know, essentially maternity leave, and then 2 weeks off for men as, you know, kind of paternity leave paid, in efforts to try to recruit the higher numbers of female surgeons coming out, and also give them something that is a little bit unique in the marketplace versus maybe what our competition offers.
Great, thanks everybody. We appreciate you all so much for joining us. I'm gonna let Clint close this out.
Thank you, Donna. Thanks, Jenny. Thanks, Mitch. And thanks, Daniel, for being here. I thought it was great content, great questions, and great conversation. Hopefully great questions, I wrote them. So thanks, everybody, for being here. What am I supposed to say here? Thank you to the University of Memphis. Thank you to SVMIC. Thank you to MedTemps for their support. I know our next MGMA event is in August. We don't have the exact date set yet, but look for your email with that. One little note I wanted to make, since we talked so much about advocacy at the end of the panel, the bills and language, they're complicated. We just put on our website TMA's legislative summary, and I say summary, it's a 7-page document, but it does a really good job of talking about the bills that impacted healthcare this year, what happened, what's next with some of those bills. 10-care reimbursement being a good example. We're going to keep going back to the table for that, so that's actually on the Memphis Medical Society website if you want more information about that. We're going to pause for maybe 2 minutes. If you're staying, I'll ask you to move towards the front. I think Dr. Bigler is going to facilitate our next discussion maybe. Yeah, thanks everybody for being here.